Hi, everyone, and welcome to today's webinar. My name is Lori Chelius, and I'm the project manager for the California Improvement Network. Today's topic will be improving care transitions, and we have representatives from Sonoma County Adult and Aging Services Program and the Santa Rosa Memorial Hospital to share with us how they've collaborated to make improvements in this area. Both of these organizations were participants in a CHCF-funded project to improve care transitions. So before we get started, just a couple of housekeeping items. We will be recording today's session, and the slides and the recording will be posted on the CIN website in about a week. If please, just for the sake of avoiding distractions, if folks could please turn off their ringers and pagers and no hold music, please. We have everyone muted for now, but just in case we open up during the Q&A, that would be appreciated. The speakers are going to talk for about 40-45 minutes, so there's some time at the end for Q&A. You can use your chat function to ask any questions. If you have any logistical questions, you can just send them to the host only, and if you have any questions for the speakers, feel free to send them to all participants so that folks can see what's being asked. You can also raise your hand if you want to ask a question in person, so to speak, but you can only do that if you dialed into WebEx first and then the phone, and we can actually see who you are. So if there's any questions with that, you can always use the chat function. So today's speakers are Gary Fontenay, is the section manager for Sonoma County Human Services Department, Adult and Aging Division. With more than 20 years combined experience as administrator and direct service provider, Gary has worked with the elderly, people with physical disabilities, developmental delays, and mental health issues in both nonprofit and government settings. In his role as section manager, Gary oversees adult protective services, in-home supportive services, and multi-purpose senior services program in the Linkages Healthy Ideas program. Gary also works with the Sonoma County Area Agency on Aging on Elder Abuse Initiatives. Our second speaker is Sue Pierce, who currently works as manager of care management at Santa Rosa Memorial Hospital. Santa Rosa Memorial Hospital is a 278-bed Level 2 trauma center serving multiple counties in the North Bay area. Susan has 25 years of experience in case management and social services in many levels of healthcare, including acute, subacute, skilled acute rehabilitation, acute psych, home health, and outpatient services. She's also worked for 3 county social services departments and understands the links between hospital and success in a home setting. And before we hand over the presentation to Gary and Sue today, Monique Parrish, who was the project manager for the CHCF project, will just give a brief overview of the project to just give a little bit of context and background. So with that, Monique, I'll hand it over to you. And if you just hold a second, you should be good to go.
Okay, great. So you can hear me now?
Yep.
Great. Good afternoon, everyone, and thank you so much, Lori. I'm thrilled to both introduce the program, the initiative, to everybody very briefly, but also to recognize it was just a huge pleasure to work with both Gary and Susan as one of our grantee sites. If you'll notice the first slide, just to kind of provide some context and framework, addresses readmissions in healthcare in the United States. Probably doesn't need a whole lot of introduction there. The data that you're looking on that slide is from Jenks and his colleagues from their article in the New England Journal of Medicine, Rehospitalization Among Patients in the Medicare Fee-for-Service Program. That article was published in 2009. And what was really compelling about that article, as we can see, is that we have, as a country, a huge problem with rehospitalization. They were looking specifically at the Medicare fee-for-service beneficiaries, but we can extrapolate from there that this is a widespread problem in general. Just again, in terms of context, just looking at the information presented, 1 in 5 patients admitted within 30 days, certainly 1 in 3 within 90. But another very compelling factor that the analysis they they did on this claims data revealed is that patients tend not, well, certainly half, aren't going to their primary care physicians within 30 days of their discharge. All of this circling back to the fact that it's just a huge impact on healthcare costs, along with certainly the quality of healthcare. In recent sort of healthcare reform focus is on improving care transitions as one element that hospital and health systems and community organizations around the country can address. So the timing is perfect, but we're going to go back in time for back a few years, and if you can advance to the next slide. So the California Healthcare Foundation in 2007-2008 decided to launch a 12-month pilot of the Care Transitions Intervention, which was developed by Dr. Eric Coleman from the University of Colorado. And Sue and Gary will explain a little bit more about the intervention. So I'll just briefly state it's a 4-week evidence-based model for those of you who may not be familiar. And it really pivots around addressing 4 key pillar areas of medication self-management, personal health record keeping, follow-up visits with primary care physicians, and of course identifying red flags, warning signs for each patient that their health condition is worsening. And this 4-week intervention was really designed to kind of enable and activate patients to take a greater role in managing their health care. And the focus of it with the transition coach is not to do for the patient, but for really a modeling and transfer of skills. The initiative by the foundation was to take this initial randomized controlled trial findings from Dr. Coleman's initial study back in the early part of 2001 and 2, and then to test it out in California with 10 sites. So they sort of announced through a request for proposal for partner hospitals and community organizations to apply and to embrace the CTI program and to develop an implementation plan that would go ahead and start running a 4-week intervention. If you go to the next slide, you can see that there were 10 sites across California that participated. And what you may not be able to recognize, you can look through the names, is these were some very unique partnerships. They were hospitals and community-based organizations. Some of the hospitals actually had their community partner embedded within the hospital. But we also had, for example, a county public hospital that partnered with a homeless shelter, again, recognizing that there was just tremendous diversity. And you'll also hear the unique aspect from Gary and Sue's experience working with this intervention. On the next slide, we were very interested in terms of project objectives. This had already been an evidence-based model, had proved some savings and some reduction of hospital readmissions, and we were very interested in implementing it in some diverse communities and recognizing whether it could be adapted and modified. And in fact, it proved to be very effective. We were also very, very keen on hosting a learning collaborative, so that each month there was a learning community call that addressed a number of topics. We had featured speakers. And ultimately, we were very, very interested in evaluating the efficacy and sustainability of this model. What would the spread or wider implementation possibilities be with this model? So the last slide is we were very, very pleased at the end of this year-long pilot. Again, each site was asked to see at least 100 patients. Not all of them were able to do that, but we did conclude the project with about 800 patients were engaged. We had some very unique partnerships, so not each partnership sort of mimicked the other. Some of them were working with the community organizations that were providing adult protective services. As I shared earlier, a homeless shelter was one of the key partners. At the end of the project, we were just delighted because 6 sites had identified a strategy to go forward either fully or partially with the care transitions intervention. And that really required sort of a buy-in from senior leadership. And we also recognized that there were a number of elements that really sort of captured the sites that were able to maintain either in part or full the intervention. So in sum, we were able to identify 3 factors for sustainability. And the first was administrative leadership. And we recognized that when health systems that are just bombarded with so many competing needs, and of course they've got the fiscal end of things and of course patient-centered care being a primary focus, but if they were not really embracing and sort of connected to this intervention, it tended to not have great adoption post the completion of the the pilot. We also recognized that within these partnerships, those partnerships that had terrific, strong management, that they had somebody who was championing within and making sure that the transition coaches were engaged, those tended to do better. And finally, consistent, dedicated transition coaches were very important. So I'm going to conclude that. I'd like to just pass this back to Lori and thank Gary and Sue for all of their work, and I look forward to the rest of the webinar. Thank you.
Great, thanks, Monique. So Gary and Sue, we are going to pass things over to you all to go ahead with the rest of your presentation. Hope you could just bear with us for a second while we, okay, you should be good now.
Hi, everybody. This is Sue. One more comment about Santa Rosa Memorial is that it's a Level 2 trauma center that serves multiple counties, Sonoma Lake, Mendocino, Napa, and the Marin County coastal region. And I only mention that because it brings from each county a different set of issues that we have all had to work with in the process. The next slide is related to what all of you, sorry, the next slide's not up yet. This one, okay. All of us are aware of major factors of readmission. This is also from the Coleman studies, but are other ones correlated. Factors in readmission, age greater than 65. I do want to say that there are indications that a younger population should be targeted for interventions in addition to the over 65 population. Low patient activation. Patients being involved in their self-care have been a challenge, and I would say in some ways the medical system has not helped this. It's sort of an illness-based model rather than a prevention or wellness-based model. Medication-related complications. Med reconciliation is one of the keynotes of the Coleman model, and every hospital in the country is struggling with this. You all know it if you live in a hospital. Inadequate transfer of information. It's really important to try and cement the transfer processes. If you think long range in terms of the success of your patients instead of it being an episodic treatment, when somebody comes into the hospital, the success rate should be higher. Especially with the electronic medical records, be creative in how you look at that. Inadequate community support is one of the other indicators for readmission, and certainly in this economy, it's showing to be harder and worse. Family systems, we have more blended families, estranged families, people who everyone is working, they have to work in this economy. All of that is a factor in the lack of support. The community systems in the social service network and the community support programs also are overburdened and overloaded, and they have an increased lack of services too. Gary and I in our discussions talked also about the impact of mental health in all of the readmission aspects. We've looked at some of our emergency room frequent readmitters, and it's probably 90 to 95% social factors and mental health factors that provide the readmission aspect of it. And Gary has seen that in the county support programs as well. This is a slide that just indicates some findings that from one of the Coleman research. The abstract is noted on the slide itself if you want to look at it and read it further. But as part of the Coleman model, a care transition coach, nurse practitioner, did a comprehensive medication assessment after the patient had discharged home within 24 to 72 hours. 14.1% had one or more discrepancies. Of those, 50.8% were discrepancies that were patient-associated, and about 49.2% were system-associated. 14.3% of the patients with medication discrepancies were readmitted at 30 days versus 6.1% who had no medication discrepancies. So what that really boils down to is whether or not you love it or hate it, medication reconciliation really matters. Healthcare redesign, you know, one of the standards for that really has been set by the CMS medical director, Donald Berwick. And in a couple of his articles that he's put out, we're really looking at handoffs more and more and more. Again, hospitals are not the isolated arenas they used to be. Handoffs will matter. And as you build your healthcare redesign and you build your systems, that's going to be really important. The second is it's about the patient's journey. Working in a hospital, systems are set up, and they are in each of the agencies. We need to flip that all the way around and start looking at our protocols based on what it looks like from the patient's standpoint. That really is a different way of looking at it, and we try and do that as well. Seamless transitions. It's part of our use of the Coleman model. It allowed us early on, 4 years ago when we tried this, we know where our gaps are. We really started working to identify the gaps and look at how we can fix those. Developing partnerships, hugely important. You cannot do it in an isolation, and none of the agencies in the community can do that either. Partner with those who have a quality standard that is equivalent to you. That's one of the other things that we really learned in developing the partnership thing. Gary and I, when we first met, had some work together, but when we started this, there was no money attached to the process. It really was for the right thing to do. So it was really for the sake of the patient that we looked at doing that. And that's a good place to start. Respect for resources. The requirement's going to be better care, better health, and less cost. And redistribution, that's going to be based on value, outcome, money cooperatively moved where it makes sense. In other words, just as an example, if it makes more sense in your continuum to look at providing private duty workers for somebody 2 hours a day in their transition period, you might want to start thinking about being creative that way. And this, again, is just a quote from Donald Berwick, again, who's the administrator for CMS that we all are responsive to. The aim is to reward value instead of volume and intensity by making providers eligible to share in savings resulting from steps that reduce overall health care costs while improving quality of care. That's where the nation's headed from that standpoint. So what does this mean for community agencies? And after I sent this slide and I sort of thought, what does this mean for hospitals as well? It's really both sides of the fence. There are new opportunities for partnerships with hospitals and physician groups. We're seeing that some places in California, also with insurance plans, that's also happening. Opportunities for creative programs that benefit the overall health of the community, different way of looking at it. Non-traditional services may be a part of the overall continuum of care. Again, that's the concept of thinking more broadly about what makes people successful in their homes and where your resources and what your gaps are. And wellness and proactive interventions. It's interesting, if you look around almost everywhere, there are new wellness approaches. There are signs, certainly Kaiser's involvement, that's their approach as well. That's where we're headed. And the key findings in the care transitions research, really, Monique spoke to this too. Patients who participated in the care transitions model were less likely to be readmitted, and this is at the time 12% versus 19% national rate. More likely to achieve their self-identified personal goals around symptom management and recovery, and to have sustainable benefits for as long as 6 months after the program ended. People are trying other models in conjunction with some of the Coleman characteristics. There are a lot of things out there now, patient navigators, et cetera, that people are starting to experiment with. But our use of the Coleman model was really because it was evidence-based. We knew it had been proven. We didn't have to prove it again.
Hi, this is Gary with the Sonoma County Adult and Aging Division. And so I want to talk a little bit about how we implemented care transitions here in Sonoma County, partnering with Santa Rosa Memorial Hospital, and why we chose to participate in this grant as a county-based aging services division. Our mission is really to help seniors and people with disabilities live at home as long as possible and as safely as possible. So from our perspective, this particular care transitions intervention fit really well with our mission and with what we're trying to do in all of our programs. And again, some of the programs we operate in our division are adult protective services, in-home supportive services, multi-purpose senior services program, which is a Medi-Cal waiver program, and then our linkages case management program. So when we heard of this grant opportunity, we already knew that we were doing some of these kinds of interventions, but not in a very systematic way. So we pretty much jumped at the chance to be a part of an evidence-based intervention and to partner with really a hospital who provides us a lot of referrals already. And we had a kind of informal relationship with and it allowed us to formalize that relationship. Also, the brevity of the model. Monique mentioned that it is a 4-week intervention. And that brevity really lends itself to the kinds of case management programs that we run here in Sonoma County. It's a short-term investment that has a pretty big impact for our client and for the hospital's patient, ultimately. In terms of how we implemented the intervention, we used social work staff from each of our programs. We actually had one social worker from Adult Protective Services, one from IHSS, In-Home Supportive Services, and one from Linkages. But primarily we used a MSW intern because the grant didn't pay for salaries. We utilized the opportunity of having an unpaid intern implement this intervention. And I have to say one of the successes of that intern is that she ended up working for Santa Rosa Memorial Hospital after her internship was over because she was able to work with them. She got to know them quite well. One of the challenges of having this intervention operated by social workers is, as Monique mentioned, it is an empowerment model. And in the social work model, we often want to do for our client. We want to complete the intervention for our client. And really, the Coleman model is really about educating and empowering the client to take on the intervention themselves, to educate themselves and learn what their medications are, learn how to speak to their physician, learn about their own disease and disease process so that they can become more educated and hopefully prevent future admissions on their own after the 4-week intervention is over. And we did see evidence of that anecdotally in our care transitions intervention. The fidelity to the model was also a challenge initially, partially because it was an empowerment model, but also because we didn't have many resources to start with. And so we were challenged with really sticking to the 4 weeks, to seeing the person in the hospital before they were discharged, because our social workers weren't on site at the hospital. That was a particular challenge, and it took us several months to get really good at how to streamline that process. And then lastly, the tools were important, and even though we haven't continued the relationship with Memorial Hospital, we hope to bring that back together. We do continue to still use personal health records in all of our programs in Sonoma County Adult and Aging, and so does Memorial Hospital. They continue to use the personal health record. We actually designed our own booklet that we made to make more user-friendly for our clients and for Memorial's patients. So that's been very helpful. The medication self-management, Sue referred to the importance of medication reconciliation. Certainly we see that in all of our programs, in our case management programs, and what a mess medications can be, and how that can really lead to an individual's decline quite rapidly if they're not following their medications properly. I mentioned the red flags earlier. Educating clients can be, in the home, can be quite difficult when they have demands around financial limitations and literacy limitations, language and cultural limitations. all of those came into play, but ultimately we were able to provide information that was provided by our public health nurse. Even though we were using social workers, we were able to provide detailed information and try to help educate not only the client but their family members as well, which was very important. And then lastly, physician follow-up. One of the training modules in the Coleman model has to do with role play and training the transitions coach how to role play with the client so that the client can practice how to speak to their physician. And many of the staff that we trained were quite skeptical about that initially. And once the intervention got going and we started to see more patients, that actually ended up being one of the most valued parts of the Coleman model, is really role-playing with the patient or the client in their home. We got more positive feedback about that component of the intervention from clients than the other three pillars of the program. So that was a very important tool. As I said earlier, the evidence-based research shows that this model significantly reduces hospital readmissions. Anecdotally, unfortunately, we weren't able to collect exact data, but anecdotally, we saw very clearly in our APS program and in our IHSS program that many of the clients that were being referred to us from Memorial Hospital were also already APS and IHSS clients. And that was our hypothesis going in to the grant, was that these are already our clients, and we started to see that pretty quickly without Memorial even trying to identify our clients. They were our clients, and what we saw is that those clients in APS that we were receiving that were medically self-neglecting, this intervention fit with perfectly. So while we didn't have specific evidence-based data on that, we certainly saw the outcomes day to day as we were doing this intervention. In Sonoma County, we did collect data on the patient activation assessment, which was one of the data collection tools that the foundation had us collect information on. And I have a few examples of data that we did collect. And one of them is that 94% of the clients we served, and we did serve right at around 100 clients during the course of the grant, 94% of them agreed to bring their personal health record to every health encounter post-intervention. 93% of our clients related that they understood the purpose of the personal health record and the importance of updating it. 93% of clients agreed to confirm their medication list with their primary care physician or specialist post-intervention. And 90% of our clients demonstrated an understanding of red flags or warning signs that their condition may be worsening. So we were particularly impressed with a lot of these statistics, and there were six other measures that were equally well received by our clients. So definitely we saw the effectiveness of the intervention from the client's perspective and the family's perspective. And then lastly, just the model does significantly reduce costs for hospitals and government agencies, and I'm assuming nonprofits as well. Because it's a preventative model, we don't see people medically self-neglecting as quickly, going into nursing facilities as quickly, and needing as many interventions, certainly from the government side of social services.
We wanted to talk just a minute about partnership development. Ours began sort of haphazardly, actually. Gary and I were both involved in another multidisciplinary process in the community and had worked together but not in any kind of project format. And he basically asked one day, hey, do you want to do this grant? And I said yes. And without thinking much about it, partly because I had the experience that I did by knowing what people need to be able to be successful at home, but partly because it was the right thing to do, and we had the rapport to do that. So I think that is huge. It's, you know, the grant period, the trial process and the struggles we took to get to a successful program were hard. And so you really need to work on the relationship and the rapport with any partners that you start to build with. Vision and leadership for community initiatives is another thing. I think that's more prevalent now because hospitals are looking out into the community and looking to see who they can partner with, as are agencies. Certainly the community clinic system is looking to partner backwards again with the hospitals in their process. But it does take, as Monique said also, it does take ownership from a leadership standpoint, and it does take somebody with vision who sees beyond those walls.
Yeah, and you know, in regards to trust and willingness to take risks, I think both Sue and I were willing to do that. I can speak for both of us when I say I don't know that our particular leadership at that moment in time were as bought in as we were. And so we both agreed to take a risk on an intervention that at that time was not the buzzword. As it is today, care transitions really is everywhere that we look now, it seems. And back in 2007, when this grant opportunity came out, it wasn't. So, you know, I think Sue and I both agreed to kind of jump together on this. I do see a question from Sophia about would we have done this without the grant opportunity? And I can speak for adult and aging. I think the support from the foundation to train us and to provide monthly technical assistance through those calls that Monique referred to were really the most vital piece. It organized us and it helped us develop our partnership more. So the funding from the foundation to me wasn't as important as that organization piece. I don't know if that answers the question or not.
You know, I would add to that we would have been working on, likely on something, because we were already doing that when we first met. That was part of the multidisciplinary process, and I think looking for opportunities from that aspect would have continued. The foundation grant provided the structure, and I know that we would have done the Coleman model simply, at least on my part, out of ignorance. It was not that well known. When we first started this, and I talked to some of the doctors at Memorial, there was one physician who's always got his head ahead of time in the quality aspects of things, and he said, "Oh my God, that's huge. Do you have any idea how huge that is?" But not many other people had that idea. So now if you say it, everybody's adopting it.
And then finally, flexibility and approach to service delivery. I think that you need to have an open mind about how your organization delivers services, and Sue referred to that earlier. And certainly in Sonoma County Adult and Aging, we're always looking for new ways to serve our clients, recognizing with limited resources we really have to be flexible in what we offer and how we offer services. I apologize, this slide, this client enrollment slide is a bit out of place. It really was meant to be earlier in the slideshow, but really what it demonstrates is how we did the handoff in the referral process. And it took us many months to streamline this process, and there's a lot of detail behind this slide that I'm not providing. But again, I think it goes back to the trust between partners, the need for ongoing communication. We were constantly on the phone with one another. We were using the opportunities at our monthly calls to have meetings with one another. And the other thing we did that's more specific is that we ID'd one contact person on each end of the sender-receiver relationship so that we weren't struggling to figure out who to talk to. Because many times Memorial was ready to discharge within several hours, and we had to have somebody in the hospital across town quite quickly. So it was really important that we trusted each other and communicated in a streamlined way. And finally, one of the biggest successes, and that we did use the grant funding for, of this particular grant, is we held a conference here in Sonoma County, and we invited pretty much the whole healthcare and social services community around aging. And we had over 100 attendees We spoke. We had our transitions coaches speak. We also had Dr. Giesecke, who Sue referred to earlier, who really ended up becoming our physician champion on this grant, and we realized, I think too late almost in the grant process, how important that physician champion was to the process. But it was a very well attended and very well received conference, and it definitely increased awareness. And I believe that today that the community is much more aware about this specific intervention and how important it is to patient quality and to people having quality of life at home because of that conference. A lot of our partners are now much more convinced and on board because of that conference. So lessons learned. I kind of referred to some of our lessons learned as I've gone along, but you know, a simple intervention can make a profound difference. I know that when we were applying for this grant, there was skepticism about, will this really do anything? It does seem so simple, educating a patient, providing medication reconciliation, you know, all of those things that we talked about earlier. And the truth is that it can make a profound effect, and it did. And it doesn't have to be intensive case management, was what we learned from the social work side for an individual to really benefit from an intervention. Education for partners is very important. Again, I'm referring to the community forum, but also as we implemented the intervention, we had calls from home health agencies that felt challenged by this specific intervention because it looked like home health to them. And so I think one of our lessons learned is that we probably would have had some kind of a community forum maybe in advance, actually, of implementing this intervention to let people know what we were doing so that there was more understanding. And finally, that the coaching model is essential to a successful intervention, that really letting the client or the patient take the lead on their own healthcare decisions and not assuming that the healthcare system or the social services system has all the answers really was a lesson learned for both, I think, Memorial and for county social services here.
And just a couple of comments. I think as we worked out our protocols, and for those of you who were starting to do projects together, hospitals are busy places, and the simpler you make the referral process and the more streamlined so that you have one person to one person as liaisons, the better your process will be. The other thing we learned was we actually started with a couple of other partners, and keeping that momentum going and keeping the updates were hard to keep the entire group involved with, which is why Memorial and Adoption were able to be successful, but there were some folks that trailed off during the year.
And so finally, 4 years later, after this grant, we, Memorial and Sonoma County Adult and Aging, and really the entire Sonoma County healthcare community, are now looking at the new CMS opportunity to apply for community care transition project funding, which is a demonstration grant, I suppose, from CMS. And we've been planning for 6 months, but the seed of the relationship we created 4 years ago has really spurred on quite a robust conversation in Sonoma County about how we move forward, how many partners we include, what model we use, whether or not it's the Coleman model or some combination of other models. And it's now moved on to Health Action, which is the Sonoma County Coalition of Healthcare Providers, who are looking at this grant application here. And I think Sue and I are both quite proud that we have this experience to look back to and to inform and educate this possible application that we'll be submitting.
Okay, Lori, back to you.
Great, thank you. Thank you guys for a great presentation. If anyone in any of the audience has questions for the presenters, feel free to put them into the chat box and we can see them. we had one that came out before, but if there's anything else, we still have a few minutes.
So I see one from Catherine Horner.
Oh, great.
What was primary care involved, and ideally, what do you think the role of primary care should be in care transitions out of the hospital?
That's a very good question. I think because when we initially did the grant, being that it was 2007, 2008, primary care was sort of ambushed because we were training people in their homes to go in with a personal health record to their primary care docs and to ask questions and ask to have their health record maintained and updated. I think we did not do a great job of educating the primary care docs. As you know, it's not that simple to get directly to them. Now, however, I would say is a prime time because everybody is aware of the payment changes forthcoming, and let me put it this way, the primary care docs that did have some experience in the process really liked it, other than a couple of times when they got asked 20 questions because people were actually speaking for themselves. But for the most part, I think that was a gap in our education to start with. If I were to do it now, I would certainly put them foremost in the process because they are very much a part of it. And done well, the care transition model actually will make the primary care docs' lives easier all the way around.
Great. We have another question. How did you develop the red flags for different diseases?
On the transitions coach end, honestly, initially what we did is the transitions coach would do the interview in the hospital, and so that was, the first step was interviewing the client in the hospital or the patient in the hospital, and if the transitions coach wasn't comfortable around that specific disease, he or she would consult with our public health nurse, talk further with the hospital liaison, which was a social worker that Sue had identified in the hospital, to get more information about anything they didn't understand. But the Coleman model doesn't expect the transitions coach to be a medical expert, which is why it doesn't have to be a nurse or a medical person who's providing the transition coaching. And so we did have fact sheets on various diseases that we would share that were provided by our public health nurse. Some of them we got off the web, quite frankly. So it was informal and iterative, if that makes any sense.
I think, again, that's sort of the difference between then and now. I think now there are some pretty good tools out there, especially around, the big three, CHF, pneumonia, AMI, and that kind of thing. So Chinese Hospital, for example, has a great pictorial one for CHF that's really patient-focused and patient-friendly. That's the kind of thing now, if we were going to do that, we would look for the most patient-friendly ways to let people know what to look for their red flags.
Great, thanks. Any other questions, or Gary, so do you see any coming to you that?
I don't have any more.
Sure. Okay, great. Just one brief announcement about next month's webinar, and feel free to send another question while I'm speaking if anyone has one. But next month's webinar is going to be held on November 16th, which is 1 week earlier due to the Thanksgiving holiday. So we'll be sending out an announcement for it next week, but we'll be hearing about the North Vallejo Access Partnership, which is a collaboration between La Clinica de la Raza and Sutter Solano Medical Center, designed to increase access to primary care and reduce inappropriate ED use. So look for an announcement, but just note that it will be a week earlier next month. So thank you all for joining, and thank you, Sue and Gary and Monique, very much for your time and presenting this great information.
Thank you.